Today we are looking at bone soft tissue, malignant bone lesions. This is the final week of our first series of bone soft tissue. And for anyone joining us on the line, please feel free to speak up or enter questions in the chat. Waiting for that to go up. We will be answering questions either throughout if you have questions, or we can answer them at the end. We'll check both ways, so let's get going. As always, we start with our disclaimer. For today, it is just me, at least at the moment. But if you have any questions about the disclaimer, I am happy to answer to the best of my abilities. All right. We have a lot of relatively loose areas that we're going to get into, so let's get started. Chondroosseous lesions, case 1. So this first case, what we notice outright is it's very lobulated. Everything seems very well circumscribed with these fibrous areas in between. And if we zoom in, what we notice right away is that we have a lot of variation in the nuclei. Some of them maybe are a little more almost popcorn or cloud-like, not popcorn cells, just kind of lumpy bumpy. Some of them are a little more smooth, some of them have prominent nucleoli, and some of them are just extremely hyperchromatic, like this guy down here. Didn't want to zoom in that much. And what we also see is that even though we have this definite myxoid type background, some of these cells kind of give us a semblance of maybe they're adipocytes or trying to be adipocytes. What else? I know I saw some of them where we have these pseudo-nuclear inclusions. So hopefully you're able to pick them out. They're kind of everywhere in this case. And trying to see if we see any other features that might help us out. If anyone knows what we're looking at, feel free to scream it out. Okay, I'm not really seeing too much of them. Like maybe this one's trying to. This one's better. That looks like a definite nuclei. Maybe that's another nuclei. This one's also doing that, and maybe you can appreciate that these are somewhat hugging adjacent tumor cells. So it looks like we have a tumor cell here, and then we have this big one over here, and sometimes you can see that. Okay, so we have this lobular architecture. We have these very large, somewhat epithelioid-looking cells with these average to large size nuclei that may have hyperchromatic nuclei. They may have, some of them have nucleoli, but when they do, they tend to be pretty small. Like we're zoomed in pretty high to be seeing these nucleoli. We do have pseudonuclear inclusions, hugging. We have those physalliferous cells, and that's okay if you're groaning a little inside whenever I try to pronounce some of these things. But okay, so overall, and you can look anywhere in this lesion. This area is a little more cellular, but it still gives the same semblance. So we have these physalliferous or adipocyte-like cells, and you see there's quite a few of them. Like look at that guy, it almost looks like a signet ring cell. So what this is chordoma. Okay, chordoma, 5% of primary malignant bone tumors, mainly affecting older adults, men more than women, and we're not surprised by that in the bone soft tissue realm. Less than 5% of them will occur in people under the age of 20. They are extremely rare in children, but when they do occur, you should look for a lesion at the skull base. B&ST is believed to be the precursor, but we don't really know what the precursor is for these. And the symptomatology is related to where this tumor is. So you need to imagine, if you will, if they have a large skull-based tumor, they might get diplopia, they could have headaches, there could be several different palsies involved. If it's involving the spine, then we would think about neurologic symptoms, maybe even pain. And involving the sacrum, so we would think about GI, GU type symptoms, erectile dysfunction, as well as pain. There is association between chordoma and tuberous sclerosis, so that's something to keep in mind as well. Grossly, so again, they're going to affect the axial skeleton. It's very rare for them not to be in the axial skeleton. So if you're seeing something that's in the long bones of the extremities, you might want to think again about whether or not it's really chordoma. These are well demarcated tan gray lesions that tend to be soft or gelatinous, and we can imagine that looking at the histology, how they have that myxoid type arrangement. They are lobulated, just like what we saw on the slide. And if you do have dedifferentiated areas, these will look more solid and be more fish flesh-like. And I know that's kind of a buzzword in sarcomas where we tend to say that quite a bit. If you have poorly differentiated areas, that's where you're going to maybe see necrosis, and you won't see myxoid type areas, so it won't look gelatinous, okay? And this is just showing you, this is a sacral tumor, both of these. So you can see the variegated appearance to it. Some of it looks hemorrhagic, maybe there's some cystic degeneration, but it doesn't look like a solid lesion. So for this one, we wouldn't think necessarily dedifferentiated or poorly differentiated based off of that gross. Your microscopy, I stuck simply with conventional chordoma, which has the lobular architecture we saw. It has those very big epithelioid type cells that we saw with those large nuclei, small nucleoli, those pseudoclusions. The cells themselves tend to be either nested or form cohesive type cords, and you may or may not see hugging of the cells. So when we think of hugging, you do think of things like mesothelioma, so somewhat similar to that. And these cells obviously have very abundant eosinophilic cytoplasm. The physioliferous cells, I will get that term down eventually, tend to have cytoplasmic vacuoles that are clear, and they can have these wisps of mucinous material. It's hard to make out on here, but when you have just sort of like these very thin, faint lines of mucinous type material within those clear spaces, that's what they mean by the wisps of mucinous material. They can look bubbly, or they can look adipocyte-like, and those are some of the things that we mentioned. You may or may not see pleomorphism. You can see spindle cells, and you may or may not see necrosis. Now remember, when we see necrosis, we start thinking about, is this poorly differentiated? The stroma itself is myxoid, but kind of has this frothy basophilic appearance, so that's all this frothy basophilic type stuff. And you don't really see mitotic activity in these tumors. If you do, it should be relatively low. There's multiple other types of chordomas, so I do recommend taking a look at them. It was a bit much for us to cover today. As far as staining, so your keratin should be strong, diffuse positive. You can see EMA positivity, S100, and your T brachyury. So this is a transcription factor, so this is something that is quite specific. And that paired with your keratin actually would be a very good panel to determine whether or not this is chordoma if you weren't convinced based off of the histology. CEA and GFAP will be variable, and your negative stains, I and I1, but only in poorly differentiated chordomas. So if you're thinking this is conventional type chordoma, don't even worry about I and I1. For molecular, sporadic chordomas tend to have an SMP in the T gene, so that's your brachyury, which is located on chromosome 6 at locus Q27, okay? Whereas familial tends to be a gain of that T gene, so instead of 2 copies, they tend to have 3 copies. There's been reports of chromosome 7 abnormalities and very complex karyotyping with chromosome 1, 3, 4, 9, 10, 13. So they almost run the whole gamut of molecular disarray when you're looking at that. So the big thing to know would be the T gene, whether it's a SNP or a gain, and everything else is just kind of background because it's not really specific for chordoma. Your differentials would be chondrosarcoma, which you can imagine, especially if it's more pleomorphic, metastatic adenocarcinoma, benign notochordal cell tumors, so that's your B&ST that we mentioned earlier, and your atypical teratoid rhabdoid tumor. For treatment, this is going to be a common theme to today's tumors. They're going to excise it and give radiation. Prognosis, okay, it depends where it is, how big it is, and can they take all of it out when they go in for surgery. So your sacral lesions will have the best prognosis, and that's because they're often able to have very good margins on these. The 5-year survival is 60 to 95%, and your 10-year survival drops down to 40 to 60, but still respectable. Your spinal lesions have high risk of local recurrence, which makes sense. There's only so much you can take from the spine. So they try to improve this by doing things like let's add neoadjuvant radiation plus surgery. So they'll if the patient has a biopsy, they'll have the biopsy, give them radiation, then they'll go to surgery, then they go back for more radiation. And that's what it means by neoadjuvant means before surgery, adjuvant means after surgery. So their 5-year survival when they do all that is about 55%. So definitely not as good as the sacral tumors, but still not too terrible. The skull-based tumors tend to have poor prognostic factors if they're related to large size, female gender, if they're greater than 40 years old, which remember is the majority of these tumors are diagnosed in people over the age of 40. And all that are poor prognostic factors. And with the skull base, even if they radiate them, about half of them will recur. I have a little bit about the chondroid poorly differentiated and dedifferentiated types in there, but since we didn't go over the histology, that's more just for your reference. And metastasis with these lesions tends to occur in the lungs, skin, and bone. So again, we have those physioliferous cells. Here you can see that very prominent nucleoli in this relatively bland looking cell. Okay, and we have just more of the very frothy basophilic stroma. Alright, chordoma. So this is case 2. And this one is a little bit of a hinger. So what we see is we have very blue areas, very pink areas, and this looks like it's probably bloody, and we have some fat down here. So if we go high power, we can confirm that yes, this is blood. We have lots and lots of red cells, but nothing looks too funny. So we're going to go into other areas where we start seeing, well, we have some rather large atypical looking cells, maybe a little myxoid change, and somewhat of maybe an inflammatory background. It's kind of hard to tell, but whatever's going on with this lesion, it's kind of blurry, which might just be the resolution it was scanned at. But it looks like maybe we have some pseudo-inclusions like we were seeing before, but it's really hard to tell. And some of these cells maybe start looking a little more spindly, but they're relatively plump overall. Look at that guy, it almost looks like a jelly bean. But okay, so not a whole heck of a lot to go on. That looks really funny. Almost like quotations. So let's zoom out and see if there's any other parts that look a little different. this looks even more terrifying. Has a little bit better resolution. I mean, look at that really coarse chromatin. Maybe that's a mitotic figure. It's hard to make out because it is so hyperchromatic. But these cells don't have, they have somewhat prominent cell borders, but not really great. Some of them do look more spindled, like this guy and this guy look a little more spindled. This stuff definitely is more spindled, but it's really hard to tell. What I'm not seeing, oh, here we go. This is definitely more spindled. Look at that. Oh my gosh, scary. Scary stuff. And again, we kind of had this lymphocytic infiltrate to kind of give you an idea of how big these cells are, how atypical this spindled population is. But okay, so if anyone has any thoughts, again, you can shout it out. And this just looks more like some fibrin deposition. What else is going on here? Oh, I kicked myself out. There we go. Okay, so that's kind of what we have going on here. So what I would really like to see with this case would be areas of some sort of osteoid formation. So I would want to hedge on this a little bit, and like this is definitely a high grade spindle cell lesion, and maybe other parts of this tumor look different. But right now, that's where I would be high-grade spindle cell lesion. Now, what I have on the next slide, which is case 3, so this is a little more conventional picture of what you might see in other areas of that tumor. So where we have some more osteoid-type cells, we have some cells that maybe look more like osteoblasts, like we saw a couple weeks ago when we did our benign bone lesions and we were looking at osteoblastomas. So areas that look very much like that. Here's kind of more of it. So we have all these osteoblast-like cells. And that would be the most common variant that you would expect to see, but who knows. If we go back to case 2 for a minute, there were areas up in here, I think it was, where it was spindled, or maybe it looked a little more herringbone, which is one of the variants that you can see with this, where it's more fibroblastic, but I think that makes it maybe even a little more difficult. But what I was trying to show with this was this is a high-grade sarcoma, questionable for extraskeletal osteosarcoma. And I am preparing for the argument to come in the comment section. So what I showed here is this is definite osteosarcoma, just to kind of give you an idea of what you would expect to see in most instances of extraskeletal osteosarcoma. It's a rare lesion, okay, only occurring in 1 to 2% of all soft tissue sarcomas and 2 to 5% of osteosarcoma. It occurs in adults aged 50 to 70, again, males more than females at almost 2 to 1, and these are malignant lesions, okay? So even though I said it's going to recapitulate a lot of what osteoblastoma looks like, these are malignant lesions. They're associated with previous radiation treatment, and this usually occurs at least 2 years after they've had treatment. And these are progressively enlarging, painful masses, or often painful. They like to occur in the thigh, buttocks, shoulder girdle, so we immediately notice that there's a bit of a transition from our chordoma, which was axial skeleton. This likes the larger girdles, larger muscle groups, but you can also see things like it can occur in the retroperitoneum, but these should pretty much always be deep soft tissue. So if this is something that's like right beneath the skin, extraskeletal osteosarcoma would be very low on your differential. These are well circumscribed tan white masses that have a huge range of size. Since if you can see 1 to 50 centimeters, so anywhere from 1 centimeter up to almost 2 feet in size. The average is 8 to 10 centimeters, which is still a very large tumor. They may or may not have necrosis or hemorrhage. We saw hemorrhage in that one lesion. And the bony elements are most prominent in the center of the lesion. We didn't see bony elements, but I am getting to that. So, on microscopy, you should have pleomorphic spindle or polygonal cells with cytologic atypia. Well, we definitely had that. You may see, you should have mitoses, and you may or may not have atypical mitoses. It was difficult to appreciate any mitotic figures, but I think that was a knowing partly to it looked slightly overstained, and the resolution maybe wasn't high enough to really appreciate mitotic activity. All variants. So regardless of the variant, you should have neoplastic bone, which when they say neoplastic bone, they mean stuff like this, where it has somewhat of a lacy or trabecular like network. You can have instances where it's sheet-like, where it's just, you know, a sea of this neoplastic bone. And the bone should be dense and in the center of the lesion as well as at the periphery. Bone should be dense and at the center of your lesion, and it should be very cellular at the periphery of the lesion. And this is completely opposite to myositis ossificans, where your bone is going to be dense at the periphery of the lesion and your cellularity is at the center. The osteoblastic variant, and this is why I had the osteosarcoma there for you to appreciate some of the elements, is the most common. So the lesional cells resemble malignant osteoblasts with abundant bone matrix. Plenty of other subtypes. So I actually wonder if the example that we had is really a fibroblastic variant because of that spindle cell area, but very difficult. And just based off of that one slide, as I said, I would leave it at high-grade spindle cell lesion. And you would have to do stains. Okay, so for stains, what do we have? CD99, ALP, Vimentin, okay, we'll say that a little tongue-in-cheek maybe, HSP73, osteocalcin, GFAP, and S100 will be variable. Your negative stains will be PLAP or PLAP, ERG, MAP2, and MET. For molecular, there is nothing really specific for extraskeletal osteosarcoma, so really you just want to get rid of your other differentials either by morphology or with your stains. So there is a lengthy list of differentials for you to go through. Treatment is going to be wide local excision, neoadjuvant radiation, adjuvant chemotherapy. And that's something to note because a lot of these lesions don't respond to chemotherapy. So that's something to keep in mind with this. Extraskeletal osteosarcoma has a very poor prognosis with a 5-year survival rate of only 25%. So this is something that you don't want to miss. But luckily it is extremely rare, and rare in the realm of sarcomas is a good thing since sarcomas themselves are relatively rare. And just giving you a little bit of a radiological appearance. So to me this almost kind of looks bubbly, again, almost kind of like popcorn or cloud-like. And then here is just kind of showing, like here you should have that malignant bone and then have the lesion around it. More of the malignant osteoid and your cells. And here's more of like an epithelioid type variant and an atypical mitotic figure. So moving on to chondrogenic lesions, this is case 4. In contrast to what we saw in the previous cases, this to me looks a lot more purple. It's not quite pink, it's not quite blue, and we have lots of blood. So we're going to avoid blood and just try to see what looks different here. It's extremely cellular, and when we zoom in, we notice that the cells are not overly pleomorphic. In fact, they're relatively bland. We have some giant cells. That's a giant cell. Or at least I think it's a giant cell. And what else can we see? Maybe some grooves. The nucleoli are somewhat inconspicuous. This is as high as I can scan in, but they're not super prominent. Like there's maybe one, there's one. The cytoplasm is very eosinophilic. Some of them look like maybe they have, like this one looks like it has 2 nucleoli. What else we got? Yeah, it's definitely a giant cell. And then we have this sort of chondroid type matrix going on. So when you start seeing these kind of features, one of the things that you want to look for, that's not showing it too well, kind of is. What I'm looking for is what's called chicken wire calcification. So this looks like it's starting to calcify, and it's basically going around all these cells. So that gives it sort of the appearance of chicken wire. Like these kind of areas where it's very defined, so it looks like that heavy wire that they'll use to form chicken fencing. Okay. I don't think there's too much more for me to say. It's really hard to make out if you have a lot of longitudinal grooves, which you should have in this entity. Like there's definitely, like here, again, 2 nucleoli, 2 nucleoli. So this is a chondroblastoma. I keep hitting that. So these are really rare tumors, less than 1% of all bone tumors. They tend to occur in adolescents to young adults, again, males more than females. And what you should know is that if the skull or temporal bone specifically is involved, that tends to occur in middle-aged adults. These involve single bones, and they tend to have long-standing localized pain that lasts years and years. So this sounds like an absolutely miserable lesion to have. The patients may have swelling associated with the lesion as well. It prefers the long bones. You can see 3/4 of cases, specifically proximal femur, proximal tibia, proximal humerus. So here we can see the humerus is involved. And these are lytic or centrally placed lesions. They tend to be fairly well demarcated. Well, we can see that. This, even on an X-ray, looks pretty well demarcated. They may or may not have a sclerotic rim or periosteal reaction with them. And often what you're going to get is curettings. And curettings are relatively nondescript. They're tan pink, they may be hemorrhagic, they may be very calcified. You may see some cystic change, possibly if they're larger pieces. But you don't have to see all that. They could just be nondescript red-brown curettings, which you'd submit for evaluation. On microscopy, so we're going to see this uniform, very round, bland cells with well-defined borders, as we saw. And it's just sheets and sheets of these very bland cells. They may or may not have longitudinal grooves There was maybe a few that we saw in our case, but I think because we couldn't scan in higher, it was very difficult to evaluate for that. We could tell that there were multiple nucleoli within individual cells and couldn't really appreciate cytologic atypia, but that still fits. What you should also find is that pericellular chicken wire calcifications. We saw some areas that looked like maybe it was trying to start those calcifications, but that's something that can really help you get to this diagnosis. Having these osteoclast-like giant cells should also be present, and there should be mitotic activity, but it should never be atypical in these. For your stains, S100, SOX9, CK8, 18, 19, P63, NSC, and vitamin. Your CD56 would be negative in these, and most of these are diploid, so you don't have to do molecular on them. Your differential would be a lot of the things that we've seen already in our benign section, which was giant cell tumor bone versus aneurysmal bone cyst, or ABC. And clear cell chondrosarcoma is another thing that you can think of with this. For treatment, they're just going to excise or curette these out, and they have a relatively low risk of local recurrence at about 15 to 20%, but if it's in the temporal bone, the recurrence rate is about 50-50. They can metastasize to the lung, but this is very rare, and even if it gets to the lung, they don't progress. So that is your chondroblastoma. Case 5. So what we have here, looks like the lesion is maybe up here. Not a radiologist, and this is where it shows. But okay, so we're looking at shoulder girdle. And this is case 5. And okay, so compared to the previous one, which looked very purple, this one has almost like a pale blue type look to it. So it's a lot less cellular. And when we get up to it, what we see is there is just bucket loads of this stroma that kind of looks myxoid, kind of looks cartilaginous maybe in some areas. And it's really hard to make out architecture. Maybe it's kind of lobular. I know I always say low power view, but this is kind of difficult to make out real architecture, but maybe there's like some vague lobular architecture. That looks a little more chondroid, so let's look at that. Okay. So yes, this is definitely cartilage, because it kind of has that glassy appearance that we see with cartilage, which would make all of these guys chondrocytes. But when we start seeing somewhat irregular nuclei, so there's some atypia associated with these chondrocytes, but not a whole heck of a lot. That guy's really big. Trying to see if we have any obvious mitotic activity, which we may or may not have. Oh, look at that. Almost looks like a Teuton, right? Alright, so it's not in your face mitotic activity, but this definitely does not look normal. So that being said, I'm sure there is mitotic activity somewhere. Let's see, do we see any areas that maybe look more necrotic or busy? Look at that, just wild. Not seeing anything overt. As far as like necrosis, which is one of the things that's often associated with these lesions. But okay, so we have a cartilaginous tumor with atypia. So that makes this a chondrosarcoma, which is also known as primary conventional chondrosarcoma or primary central chondrosarcoma. This accounts for 20% of malignant bone tumors, so quite a good chunk of malignant bone tumors will be chondrosarcoma. And conventional type will account for 85% of all chondrosarcomas. These are older adults, slight male predominance, and they tend to be associated with localized pain and swelling. And they can also be associated with early hormones, so ER positive breast cancer. Grossly, these tend to occur on the pelvis, greater than the femur. So here we have the femur, and you can see how chondroid this looks. It has a very gelatinous meniscus type look to it, but pretty much you're looking at it can affect about anywhere. If you're looking at the trunk, almost all of them will involve the ribs, and as we can see here, this is kind of what I was getting at. The translucent or blue-gray white surface, it may have a lobulated appearance, like down here it looks maybe more lobulated, and that's where you should know, like that's the cartilage part of the lesion. You'll see a thickened cortex, which maybe this is thickened in response. This looks normal up here on the head of the femur. You may or may not see myxoid change or cystic change. You can see calcifications, but not always, and you may or may not see soft tissue infiltration. So there's a lot of extra things that you can see with these, but this type of appearance is a very good thing to keep in mind, especially with this lobulated projection. So on microscopy, we're going to see a lot of that cartilaginous matrix, which is kind of what this is showing. It's a little pale here, so it almost just looks like empty space. And you may or may not have fibroseptate or bony tuberculae even between things. You can see endochondroma, which we went over chondromas, endochondromas, and echondromas when we did our benign bone lesions. So you may see a little remnant of that, and if you do, it should be calcified. There will be chondrocyte atypia, which we definitely saw. Variable pleomorphism, yeah, we sure had a lot of that. You should have mitoses as well as necrosis. I didn't really appreciate that on our slide, but it also looked like it was reaming, so we might not have everything that's present within that lesion. For your stains, collagen 2, which makes sense given the matrix. CD56 is positive in 50% of cases, and IDH1 will be positive in 20% of cases. Desmin and P63 will be negative, and for molecular, they can harbor an IDH1 mutation, so if they do, that's where your IDH1 would be positive. Your differential would be chondroma versus well-differentiated chondrosarcoma, as well as osteosarcoma. For treatment, they can do a curetting, like what we had in our example, and they can also do an en bloc resection. 5-year survival really depends on grade, so your low grade or well-differentiated has an 83% 5-year survival, and your higher grade chondrosarcomas has about a 50% 5-year survival. So again, we can just see this really cartilaginous appearance to the lesion. This is case 6. So again, here we have our nondescript soft tissue. Here is obviously our lesion, so I'm just going to zoom in on that. And what we notice is that we have a very biphasic appearance right away, where we have areas that are really pink and areas that are kind of blue, and there's kind of almost an edematous look maybe in between. And if we zoom in even more, what we see are everyone's favorites, small round blue cells, and maybe some cartilaginous areas. I know it looks more pink, but that kind of has the appearance of cartilage. Yeah. I think like this looks like cartilage, so even though it's pink, I think that's consistent. What else can we see? This, besides the biphasic pattern, the small round blue cells. Since there was a question earlier today on a post asking about small round blue cell tumors, and the round cell component of this tumor was brought up as part of the differential, which is totally fair. You can see there's not a lot of architecture to really help you. There's scattered vessels. In this lesion, they may or may not have myopericytoma-like vasculature. But pretty much what I'm appreciating is the biphasic pattern. There you go. Myopericytoma-like pattern, which is common with this. And again, this definitely looks more cartilaginous. Hopefully that's appreciable on the video. But if not, I would spend a little time with the whole slide images so you can really appreciate what this tumor has to offer. The cells themselves, well, some of them have more open chromatin, some of them are more hyperchromatic. It's really hard to tell if there's any mitotic activity in this. Again, this is the highest that is available to scan in. But there doesn't seem to be like a really specific arrangement of these cells. They're just kind of like nested maybe in some areas. Some areas look more like islands. Some areas have more of like a trabeculated appearance. But the big thing is that biphasic pattern. Okay, so when you're looking at stuff like this, having this type of stroma with this biphasic pattern, this is mesenchymal chondrosarcoma. Very rare, less than 3% of primary chondrosarcomas, and right, we know our chondrosarcomas aren't overly common to begin with. No age predilection, but on average it's young adults. No sex predilection, and this gives localized pain and swelling, and we're talking between days to years. There can also be oncogenic osteomalacia associated with this. It can involve any bone and sometimes even visceral soft tissues, and quite a few of them are found, I think 1/3 to 1/5, so that's 20 to 33% are found in somatic soft tissue or meninges. These are very destructive lesions that tend to be gray pink or gray white. They can be firm or soft. They can be, they are well defined. They are well defined, and a huge range in size again, from 3 centimeters to 30 centimeters or 1 foot in size. You may or may not see calcification, necrosis, hemorrhage, or cartilaginous differentiation with them. Definitely with our case, it didn't look like it was fully at chondroid differentiation, but there was some chondroid elements to it on microscopy. So here's that biphasic pattern. You can appreciate that down here and a little bit here. So these are very small round ovoid cells with scant cytoplasm. So this is your definition of your small round blue cell with an islands of hyaline cartilage. Well, I don't know that we necessarily had islands of hyaline cartilage, but we had areas that looked like hyaline cartilage. And definitely can appreciate how this would simulate a Ewing sarcoma. You may or may not have myoperiocytoma like vasculature. This is a relatively common feature, but you don't have to have it. You may have osteoclast-like giant cells, so again, those multinucleated giant cells, and you can have osteoid-like matrix. So lots of things, but you can appreciate how destructive these lesions can be. The small cells will be positive for SOX9, CD99, and Desmond, and your small cells will also be negative for FLE1 and CD45. The molecular is an in-frame fusion of HEY1, NACA2, so that's exon 4 and 13 on between chromosome 8q21.1 and 8q13.3, so that sounds like a fun thing that maybe they would ask about on boards, because any of these minor details are things that they love to ask about on exams. Your differential would be very similar to your conventional type chondrosarcoma, and for treatment they're going to do an en bloc resection. So remember, with our chondrosarcoma they might have done curettage or excision. This they're going to do en bloc resection, and they may or may not do chemotherapy. 5-year survival is 55%, and with distant mets may actually be seen like 20 years after the fact. And when you consider, again, like we go back to these lesions where they predominantly are seen in younger adults, if you have a 20-year-old that is diagnosed with a mesenchymal chondrosarcoma, well, 20 years later they're only 40, so that's something to think about. Again, here you can just see how they're poorly differentiated small red blue cells. Case 7. And if I'm going too fast for anyone, please say something and I will happily slow down. Okay, so this lesion, right away we see the bone. That's a part of that. And we see areas of blue, areas of pink. So let's go down and see what this looks like. Alright, so this looks like maybe it's trying to be cartilaginous, kind of hard to tell. But these are definitely our tumor cells. And what we have are very large cells. It's almost like they're trying to mimic like adipocytes, but those central nuclei are wrong, right? The placement of adipocytes, immature, like adipoblasts, will have large central nuclei, but they shouldn't be quite this big. So that's already something that we notice is unusual. So even if you're thinking maybe this is fat, that should clue you in that there's something else going on here. We have huge nucleoli. Not sure if you can appreciate that, but they're almost the entire nucleus is like one big nuclei, and they kind of almost have that cherry red appearance, which the cherry red nucleoli is usually a signal for us to think about melanoma, but other cells can have cherry red nucleoli, so don't let that fool you. What else? The cytoplasm that they have is relatively frothy, it's pale, some of them are maybe more eosinophilic. We have some osteoclast-like giant cells, like there's one, it might actually just be an osteoclast. There's more of them. Or the osteoclast-like lesions, or class-like cells, sorry. The bone looks at least reactive. No, this is woven. So if I'm following the lines here on the bone, it's not a smooth line. It's kind of jagged, almost like a jigsaw puzzle. So that is woven bone. And here's another osteoclast-like giant cell. Okay, so putting all this stuff together, we have these big, large clear cells. We have chondroid type areas. We have bony type areas. So this is a clear cell chondrosarcoma. And if you wanted to look in other areas, even at low power, you can tell all these areas kind of have a similar appearance. But even if we go up here, you can see those very large nucleoli and this clear cell appearance. So clear cell chondrosarcoma. Rare again, 2% of chondrosarcomas. This tends to occur in adolescents, but all the way up to our elderly patients, average of 25 to 50 years old. And males definitely predominate in this at a 3-to-1 ratio. And these lesions cause persistent pain for years. So these patients will be suffering for years at a time. So that again seems to be a relatively common theme with a lot of these lesions, is that they're very painful. Grossly can involve any bone, but most cases involve either the humerus or femoral head. So as you can see from the pictures, these are well-defined lytic lesions that involve the epiphysis, and on gross, they're going to be very soft, and they may have some gritty material, and they range in size from 2 to 13 centimeters, so a little smaller than some of the other lesions we have encountered tonight. They don't have cartilaginous features, okay? So that's kind of important to note, because we're calling this a chondrosarcoma, but we're saying that grossly it doesn't have cartilaginous features. On microscopy, you're going to have sheets of those very large round nuclei with central nucleoli. They'll have that very pale, clear, sometimes eosinophilic cytoplasm that we saw that kind of has that bubbly appearance, and they have very well-defined cytoplasmic membranes. You will see those osteoclast-like giant cells, which is what's here, and they you may or may not have areas of low-grade chondrosarcoma. So you'd want to go back, review the conventional chondrosarcoma, because you can have areas that look like that. You may or may not have woven bone. The example that we did, the bone looked more woven, at least in the areas where we were focusing more on the bone, and you may or may not see cystic degeneration with these lesions. Your positive stains include PAS, right? You may have those clear cells are filled with glycogen, so they're going to be PAS positive, which again is not IHC, that's a histochemical stain, but I like just keeping all the stains together. S100 will be positive, as will collagen 2 and collagen 10. Your negative stains would be that IDH1, R132H. For molecular, we have a whole host of molecular, which is something we haven't seen with a lot of these lesions. So P53 overexpression, CDKN2A mutations, losses of chromosome 9, gains of chromosome 20. So a lot of different things to look at with these. Your differential is a lot of things we've already covered, but you want to add in metastatic clear cell renal cell carcinoma. So maybe throwing a PAX5 on that may be helpful. Treatment, they're going to do en bloc resection. 5-year survival is 92%, so that's really good. These tend to metastasize to the lungs or other bones, and when they do, the mortality rate is about 15%. So again, here's just another view of those beautiful glycogenated cells. Clear cell chondrosarcoma. So now we're going to move on to our osteogenic lesions. This is case 8. So we're going back into the purple type, very cellular lesions, which also looks like it has maybe some bone component to it. Alright, definitely we have bone. what does our actual tumor lesion look like? Well, we have a lot of vascular spaces, looks like. The cells themselves kind of look epithelioid, somewhat spindled. Cytoplasm is really eosinophilic. These ones don't look as scary, and this is kind of an important feature to note. That when they're surrounded by bone, they don't look as bad. Like this doesn't look so bad. We can see like the definite pleomorphism in those cells. And okay. So we have a high-grade sarcoma involving the bone. If you had to take a stab at it, the best thing to guess, which is what this is conventional osteosarcoma. And why? Because it's the most common primary high-grade sarcoma of the bone. It predominantly affects adolescents and middle-aged adults. There's a slight male predominance, and this is also the most common radiation-induced sarcoma. Okay, so it accounts for 2.7 to 5.5% of osteosarcoma. And that's important since when we were discussing our soft tissue sarcomas, we looked at angiosarcoma and its association with previous radiation treatment. Again, this can involve any bone, but it prefers the long bones of the extremities, so your distal femur, proximal tibia, proximal humerus, and then everything else. It affects the metaphysis in almost all cases. So when you think about, okay, it affects the metaphysis, so we can see that the growth rate and growth plate are involved with this tumor. So again, associated with that really rapid growth. These can be multifocal about a fifth of the time, and when they do, then they often have Paget's disease of bone. These are very large tan-gray to gray white gritty lesions that are 5 to 10 centimeters in size on average. Your calcified areas are going to be tan white, whereas your non-mineralized or non-calcified or cartilaginous components will be gray. They may be glistening from the cartilaginous component, which also would tell you a myxoid element. And they also tend to have hemorrhage as well as cystic changes. Wide appearance to these tumors, but what they all have in common is diffuse replacement of that marrow space. The pleomorphism of the cells is common, so again, we saw that. We only had to search a few areas to see a lot of pleomorphic nuclei, and it's often marked, okay? The bone itself is destroyed, and the cells again, so we have epithelioid, plasmacytoid, fusiform, small round or spindled cells. So pretty much the entire gamut of sarcomatous cell types is what you can see in this tumor. The cytoplasm is often eosinophilic or clear, and what I was trying to point out is that the cells normalize when surrounded by bone, so they're not as pleomorphic, they're not as scary, but only when surrounded by bone. Yeah, see more of that scary stuff. Positive stains, we have osteocalcin, osteonectin, S100, actin, SMA, GFAP, CD99, keratins, EMA, so lots of things to try and get positive. Negative stains, so factor 8, CD31, CD45, so your vascular markers are going to be negative, okay? Molecular, complex karyotype. And the reason I wrote CWHO for examples is because it's about a page of different karyotype examples that they've seen with conventional osteosarcoma. So pretty much when that happens, there's nothing really for you to pin down with this to nail a diagnosis. Again, they're going to do an en bloc resection as well as chemotherapy. The 5-year survival rate is 60 to 75%, which is very good. And metastasis to the lungs or other sites occurs in 5 to 40% of cases. So your conventional osteosarcoma, so again, just seeing that pleomorphism. Here you can almost appreciate how it would look like our mesenchymal chondrosarcoma. Case 9. So here, obviously, is our lesion. Again, I'm not a radiologist, but this is abnormal. And if we go to the case, what we notice is very different from this one is that the slide looks pretty empty. There's not a lot of cells here. But let's get going. So the appearance of the bone, because all this pink stuff is bone, it's very characteristic in that they are parallel, and that's usually a buzzword for this lesion. But let's go to the money-making area, which is down here. And what we can see here is that even though most of the tumor is like this, where it's very hypocellular, when we go to the areas that are a little more cellular, it's just so that we can appreciate the cells a bit easier. So that we see that these are very nondescript spindled cells that are running intravaculae. They're running in rows, and they're not only is the bone parallel to that, but they are parallel to each other. You can see osteoblasts. I don't remember seeing many, if any, on this case. It's just very, very bland. And most cases actually will be hypocellular, so most cases will look very similar to this. Maybe that's one. I don't know. I'm not totally convinced of that, and you don't need them either, so is there some osteoblastic rimming? Yeah, maybe here some osteoblastic rimming. What else can you see? Kind of it to show you on this slide. So the parallel appearance, that's the biggest thing to help you. Osteoblastic rimming. I apologize because I think I said osteoclast giant cells, which I don't think are associated with this, but that's why we have notes and why the slides are coming up. But it does look like there's some areas where you have osteoblastic rimming. So that's something that you can see with this, but again, you don't have to see it. Oh, we got knocked out. I'm sorry, I don't know when that happened. Probably a while ago. Okay, so this is periosteal osteosarcoma, and it's rare, but it's the most common osteosarcoma on the surface of the bone. So it accounts for 4% of osteosarcomas, and this is predominantly in young adults. There's a slight female predominance, and whereas a lot of other lesions were painful, this is a painless swelling with decreased range of motion, but if it presented painful, there would often be associated swelling with it. This occurs predominantly in the distal posterior femur in 70% of cases, so that's what we're showing here. The tumor tends to wrap itself around the involved bone, so you can see the decreased mineralization, like I mentioned, and it's a hard lobulated mass that's closely affixed to the cortical surface. Well, that makes sense because it's a bony lesion involving the bone. You may or may not have cartilaginous nodules, so it can simulate the cap that you would see with osteochondroma, so that's something to keep in mind as part of the differential. You may or may not have invasion of soft tissues, and you can have dedifferentiation of soft, fleshy areas. And if you have those where they look more fleshy, you must sample them. Okay, I can't stress that enough. Microscopy, we have, again, these very bland spindle cells. We kind of went over a lot of that. Again, you may or may not have osteoblastic brimming. Majority of these cases are hypocellular, and if they are hypercellular, you would expect to see maybe some moderate atypia. Can see cartilaginous differentiation, which again, that would be that cap that would simulate osteochondroma. And for dedifferentiation, we would expect to see high-grade spindle cells. MDM2 and CDK4 would be positive stains, and your negative stains would be things like CD34. For molecular, it likes to have the supernumerary ring chromosomes, and that would be like chromosome 12q13 to 15 can be amplified, and that's your MDM2 CDK4, which is amplified in the majority of cases. Not a very wide differential on this. Again, they're going to do an en-bloc resection, and your 5-year survival is 90%. So you can see how this tumor just tracks along the surface of the bone. So that's your periosteal osteosarcoma. And here, since so many of these lesions really depend on where they are, where they're seeing the lesions radiographically, I thought this might be helpful to just kind of review where things tend to occur. And our last case should not be unexpected. Have to talk about Ewing sarcoma, right? So here you can see there's some lifting of the periosteum, and here is where your lesion would be. On MRI, again, you have this somewhat nondescript area, and that's about as far as I'm going to go on an MRI. Okay, so immediately when we're looking at this, you can appreciate at low power why mesenchymal chondrosarcoma and Ewing sarcoma look so similar. But let's zoom in. Obviously, this is our lesion. This is nondescript soft tissue, so we're not going to take time. And as soon as you get to medium power, you notice that the arrangement is very different. Okay, so we have these very pink areas with lots of vessels, and then our sea of small round blue cells. Now, what you should notice with these is that even though they're small round blue cells, they're relatively monotonous. The chromatin isn't really coarsely granulated. There's obviously, because of the name, small round blue cells, we're not talking a lot of cytoplasm, but where there is cytoplasm, like here, it's very intensely eosinophilic, and you can't really make out cytoplasmic membranes. So that's all good for Ewing sarcoma. There are, again, huge amounts of variants of architecture involving Ewing sarcoma. However, that's the base for all of them. Have your pseudorosettes, but pretty much what you should have is just the sea of small round blue cells and the vessels, okay? And that, unfortunately, is as far as I can zoom in on this case, but hopefully you can appreciate, even at this power, that even though the cell borders are relatively nondescript, they're the nuclei themselves are a little more distinct than what we saw in the mesenchymal chondrosarcoma. But this type of appearance is basically what Ewing's has all the time. It's just, like I said, the architecture will be different. So here's some areas that are a little looser, but you can still make out that, okay, some pseudorosettes. Alright, Ewing sarcoma. So we talk about it all the time, but it's relatively uncommon. 68% of primary malignant bone tumors, and it's the second most common sarcoma bone when we're looking at peds or young adults. We see it most often in adolescents and young adults. 80%, more than 80% of your cases are going to occur in people under the age of 20, and there's a very slight male predominance. It occurs in Caucasians more than other ethnic groups, and it's associated with extreme pain. And when we say extreme pain, we mean you're asleep and this wakes you up in the dead of night. So extreme pain, there may or may not be a mass in the painful area. Some patients will have B symptoms, like they'll have fever. It can be associated with pathologic fractures. It likes to occur in the diaphysis and metaphyseal portion of the long bones, so femur, tibia, humerus, and you can really imagine that if it was in the femur or the tibia, since those are load-bearing, pathologic fractures would be a real concern with that. Something else to note is that 10 to 20% of these are extraskeletal. So this was something that we covered in the malignant soft tissue. They have this moth-eaten appearance that you can hopefully appreciate, where it's just sort of raggedy. Grossly, they are tan gray with very destructive, ill-defined borders and invasive margins. They're hemorrhagic and necrotic. They may even appear purulent when you get them in the gross room. And often, as you can hopefully appreciate from the imaging here, affecting the medullary shaft of the long bones. So, and you can also sometimes see soft tissue involvement. Again, this is kind of all I went over, was just the classic Ewing base. And again, you don't have to have pseudo-rosettes, but the cells themselves, like that's the base that you really need to know, because there's a lot of variants, and we simply just do not have time to go over them all. We would have to do a lecture entirely on Ewing sarcoma to go over all of them. Positive stains, well, you got a whole host of them. CD99 would be membranous and diffuse, so that sounds like a good one. SNV5 is nuclear. I'm always a fan of nuclear stains. FLE1, skip over that. NKX 2.2, P16, ERG, a whole bunch of variable stains and rare stains. Negative stains, so any of your actins, a lot of your CD markers. So if you were worried that is this a lymphoma, which is a very practical concern, it's going to be negative for all of those. Negative for factor 8, HMB45. So if you're worried about cystic melanoma, again, we go back into a lot of the markers like WT1 if you're worried about Wilms tumor, because again, is this looking more like blastomol? So things that you need to think about, especially when we're looking at a lot of these will involve pediatric patients. Molecular, okay, when molecular gets an entire page to itself, here's the one to know. EWSR1, FLE1 oncoprotein, T1122, Q24, Q212, 85%. That's the one you want to do, and what you can see is that the EWSR1 is very promiscuous. It has a lot of different partners, okay? So that's really your money maker. Here's showing the CD99, diffuse membranous and cytoplasmic, PAS positivity. That is that. Okay, your differential. So metastatic small round blue cell tumors, including neuroblastoma, lymphomas, small cell osteosarcoma, mesenchymal chondrosarcoma. Again, like you can see why that's in the differential. They're going to do chemotherapy, en bloc resection, and then they may do radiation. 5-year survival rate, 70%. That sounds pretty good. They tend to get local disease, however, and 15 to 30% of them will develop metastases. Poor prognostic factors include, is it disseminated? if they have these abnormalities when you do molecular studies. And you also obviously have to consider what's the overall stage, what's the location, was there tumor necrosis after induction chemotherapy. There's a lot of things to consider with prognosis of these cases. Okay, and that's what we have for this week. So I hope you enjoyed the bone soft tissue series. For our challenge cases, we have 21 cases from bone soft tissue, malignant bone and cartilage lesions. As always, if I missed something, if I need to clarify something, please let me know so that we can all learn from each other and grow. These cases obviously are very difficult, and it's understandable that seeing one slide, not having history, that can make these difficult, bordering on impossible. Okay, so don't fret if you're having difficulty with them. Just try to come up with a differential, try to go through some of the points that we discussed. No one's stopping you from flipping through the handout. That if you go, I'm in the presentation, and I don't know if you'll be able to see this, but up at the top there is this paperclip that says attachments. So if you go there, you can see there's the PDF here of bone soft tissue lesions 4, and you just download that, and that's your handout. It has everything from the bone soft tissue series, because every week I add on, and you can sit down and flip through that. There's always extra things in those handouts to try and help you out, help you form more of a differential, trying to look at, okay, if I'm thinking benign versus malignant, how do I go from there? How do I stage these things? Because these are very difficult. Other than that, if you have comments beyond the cases themselves, I'm happy to hear those. If you have things that you would like to see in future slide reviews, future short reviews, please let me know. You can follow me on Twitter. I have both my Twitter handles below there. The link as well below for all our other videos. And if you did like this video, please hit like. If you are on social media, we'd really appreciate it if you shared this on social media, because the more we grow, it just helps everyone learn more. And if you aren't subscribed to us, at some point it should be showing up over top of this video. You can hit subscribe so that you're notified when we have new materials out, and we will see you next time on Slide Review.